the talks. Next, we'll move on to pathophysiology of the optic nerve cupping from glaucoma, retinal, and neurological conditions to be talked about by Dr. Shweta Tripathi. Dr. Shweta Tripathi did her fellowship in glaucoma from Shankar Nethralaya, and presently she's a senior consultant at the Indira Gandhi Eye Hospital at Lucknow. Over to you, Dr. Shweta.
Okay. Yeah, no, it's there. A very good afternoon to all, and thank you, Chandrama ma'am, for having me a part of this IC. So we'll talk about and understand about the ONH cupping when it comes to the glaucomatous conditions or some other non-glaucomatous conditions as well. So before that, we solve this conundrum. Let's have a look over the history of ONH, its association in the field of glaucoma. So that was far back in 1857 when von Graefe first described the association of ONH with glaucoma, and after that there was progression till 1973 when the retinal nerve fibrillary association was established by Hoyt et al. And after that, as we all know, there was no looking back. So when we talk about glaucoma, the first thing comes in our mind is two things. One is the increased pressure, and second is the cupping. Though cupping is always known as a well-recognized feature of glaucoma, but yet, of course, it is not the pathognomic feature of glaucoma, because there are certain other non-glaucomatous conditions like some ischemic condition, compressive neuropathies. So many things are there, some inflammatory conditions which lead to the glaucomatous cupping. So in all we can say, because these are the conditions where we need to establish a well-differentiating feature, whether it's a glaucomatous cupping or a non-glaucomatous cupping. And when we go in the favor of the non-glaucomatous cupping, we have to look and focus on the signs of pallor. Because different studies have also established, like here what one I have mentioned here is, like 44% of eyes by Trobe et al. Showed that they were having actually the non-glaucomatous cupping, I can say the neuropathy. Cupping would be not the correct word, it's a neuropathy, who were misdiagnosed to have glaucoma instead of a non-glaucomatous pathology. So now we look at the pallor, we say that it's a subjective sign again. So that means subject to variation, and it will depend on the individual assessment also. So for that, to make a established diagnosis, we need to go in the details of the history, which is going to be covered by my subsequent speakers. So with that, we talk about glaucoma once again. We come back to the pavilion and talk about the glaucoma neuropathy, which is basically because of the loss of the retinal ganglion cells, where some pressure related or the pressure independent mechanisms, they do play an important role, and the end result is about the apoptosis, whether it's any nitric oxide neurotoxicity or something else, which all lead to the death of the retinal ganglion cells. So now let's understand that actually what happens, how this cupping is actually occurring, whether it's a glaucomatous condition or a non-glaucomatous condition. For that, we need to understand the optic disc in three portions. One would be the prelamina, second would be the lamina, and third is the retrolamina portion. So now, as we all know, it's written, documented everywhere, there are several million of retinal ganglion cell axons which pass and they exit the eye from an inner lining of, we can say, Bruch's membrane opening, and outer covering would be which is provided by the scleral canal or the neural canal. Now when it goes via this neural canal, the narrowing happens, and there these axons are laden by basement membranes, pericytes covering the basement membranes, and connective tissue beams. All together they are known as lamina cribrosa, where we have to focus on. So now, when we again come to this particular pinkish color of the optic disc, which we all are aware of, it is basically because of the vessels supplying from the posterior ciliary artery, and this is the only visible part of the ONH which we see and we say as optic disc. So now, again understanding the blood supply of the ONH, only then we can understand that actually what is happening which is leading to that cupping. So we need to understand with this schematic representation of the lamina cribrosa, as we can see here, that there are capillaries surrounded by the basement membrane, astrocyte, the extracellular matrix, everything. And these are the adjoining axons. These are the adjoining axons. So basically the diffusion of the nutrition, because anything to survive needs a nutrition. So for that nutrition, the nutrition comes from the basement membranes of the capillaries going to the astrocytes and then to the adjoining axons. So for any reason, if there is damage, or I can say and these capillaries are derived from the posterior ciliary arteries, which I've mentioned in the previous slide. So for any reason, if this supply is hampered, or I can say that any scleral stretching from where the axons is coming out, that is tarnishing the diffusion coefficient of the axons, definitely this is going to cause a retinal ganglion cell death. Now again we come back to the blood flow once again, and here we know that the blood flow in the ONH is basically auto-regulated. But besides that, we all know that in glaucoma several other factors are working together. So could be a non-IOP related factor or could be a IOP induced factor. Anything which is going to affect this posterior ciliary artery is going to further affect the blood supply here, further leading to the death of the retinal ganglion cells, and this is what all happens. So now when we talk about the non-IOP related factors, could be the fluctuations in the BP, and that is why besides IOP, BP fluctuation is supposed to be one of the important factors when it comes to your progressive glaucoma cases. Now any IOP induced factors, maybe even this compression of this, because here when it is coming out, here the posterior ciliary artery, if it is compressed in the neural canal, definitely that is going to have the impaired blood supply. So now the basic part is to understand the cupping. It can be divided into two components. One would be the prelaminar flow, that is the shallow form of the cupping, where basically it is only the loss of the retinal ganglion cells. And the other form, which is a most important form, and actually it is encountered in the cases of glaucoma, that's a deep cupping, that's a lamina thinning. Here, besides the lamina cribrosa, the adjoining scleral connective tissue, it gets hampered. So now, basically now we can say, and we understand in a better way, that cupping is nothing, it's just a manifestation of the neuropathy which is happening in the glaucomatous eyes. So now, looking at this, again the schematic representation of the neural canal here, as we can see that this is the opening of the Bowman's membrane, Bruch's membrane, and this is the reference plane, and here we can see this is the anterior scleral ring. So now in the shallow cupping, as we can see here now, the cupping we know, there are two types of cupping, the shallow cupping and the deep cupping. Now when we talk about the shallow cupping, here as we can see that all the damage is occurring anterior to the lamina cribrosa. But when we talk about the deep cupping, which is actually a glaucomatous cupping, we see that the adjoining scleral tissue, the connective tissue is also getting involved. And once damage occurs here, then this becomes more prone to sustenance or to any kind of intraocular pressure, which further leads to the progression of the cupping. So in all, we can say that even any kind of damage which is happening here, it is always manifesting first in the optic disc, whether it's a shallow cupping or it's a deep cupping. So now again when we talk about the glaucomatous cupping, now we can say that the progressive deformation and excavation of the tissues of the optic nerve head adjoining beneath the Bruch's membrane and the anterior rim of the scleral canal, that is, as again we see here, that is the anterior rim of the scleral canal and beneath the Bruch's membrane. This is actually which is what is happening in glaucomatous eyes. So now with that we come to some of the non-glaucomatous cupping, as I already said, that could be because of the insult due to ischemia, inflammatory or any compressive lesion. So now here the feature is going to be a kind of shallow cupping. That is, the damage is happening. Yes, of course it is happening, but at the level of the retinal ganglion cells. It is not going beyond that, and that is leading to the pallor and atrophy of the ONH. So now this is AION, and so it's a non-glaucomatous. Now if we see vaguely, we can say it's a glaucomatous cupping looking at the disc status, but actually it is not. It is the pallor which is preceded by an incidence of AION. That is an ischemic insult to the eye. And last but not the least would be this condition we should never forget whenever we are talking about a glaucoma or a non-glaucomatous eye. This is physiological cupping. Now we come to some of the variations of the optic disc associations. And so only if we follow the 5 rules of an optic nerve head evaluation, we are never going to miss a glaucomatous or a non-glaucomatous cause of the neuropathy. Though I'm not going in the details of the clinical conditions because they are going to be covered, but yes, some of the compressive neuropathies where we have to take a history importantly about the central vision acuity and the color visions, because these are the things which are spared in cases of advanced glaucomas as well. Now talking about some of the toxic neuropathies, all are because of the mitochondrial dysfunctions. So yes, they are difficult to differentiate between a glaucomatous cupping, but only if we take a proper history, we can come to a conclusive diagnosis. And with that, I conclude just sharing some tips and tricks that only if we take a proper patient history, a algorithm can be set to make a differential diagnosis with a proper visual functioning, neuroimaging, and blood investigations if need be. So the take-home message would be that diagnosis is seeing in totality. It should not come as a mirage, seeing and making a diagnosis. Thank you.